I'll start to talk about fibroids now, if we can move on to the next slide. Thank you. So just again, a bit of a revision about what fibroids are and their impact. So fibroids are non-cancerous growths that can occur within the muscle wall of the womb, or they could protrude as kind of lumps into either the interior, the uterine cavity, or outside of the womb into the pelvic space. They're very common, and for some reason which we don't know, more common in Black women. And although not everybody experiences symptoms such as heavy bleeding and pain and feelings of bloatiness, about a quarter of women will seek, with fibroids, will seek treatment. Now, hysterectomy, the removal of the womb, is obviously the definitive treatment, but of course many women would want to avoid this procedure for various reasons. So whilst there have been some newer medical and surgical options, I'm not going to discuss, the removal of the fibroids themselves by a procedure called myomectomy, a surgical procedure, or a less invasive technique called uterine artery embolization, which I'm going to abbreviate to UAE. These are the main non-pharmacological options, and they were the focus of the FEM clinical trial. So next slide, thanks. Again, as similarly, the FEM trial recruited a representative sample of symptomatic women who were willing to have either procedure. And we followed them up over 4 years, which was longer than any other randomized controlled trial. And again, at intervals, they received a questionnaire which asked about the impact of their fibroid symptoms on the quality of life and the severity of symptoms. These questionnaires, as you see, they produce a score, this time 0 to 100, where 100 is the best. And at the main time point, at 2 years, 81% of those randomized produced data. And whilst both groups again reported a substantial improvement in their quality of life scores from preoperatively, those that had been allocated to myomectomy, that's the surgical procedure, had on average a score 8 points higher than those in the UAE group. And that was both statistically significant and consistent with a small to moderate clinical improvement. Next slide, thanks. If we look a little more closely at the trial, and this reflects the fact that, you know, everybody has a choice even if they're committed to a trial. We can see that 85% of those allocated to myomectomy had the procedure, whilst 80% of those allocated to the UAE had that performed as their initial procedures. So you know, there was a few dropouts or people that were then unsuitable for the surgery. By 4 years, quality of life completion rates had dropped from about the 81% on average to 64 and 53% respectively. And that, as we see, reflects the difficulty in keeping contact with participants over a long time frame. Unfortunately, that does limit the generalizability. And as you might expect, as menstrual bleeding reporting was more incomplete because, once again, the age group was in the early 40s, and so by a few years later, some were entering the perimenopause. So if we move on, looking at this fibroid-related quality of life score, at 2 years, the improvement was from a baseline of around 40 to the low 80s, and that persisted out to 4 years. Indeed, was perhaps a few points higher, 86 and 90 respectively. But that 8-point difference has now decreased to about 5 points, which is less likely to be clinically meaningful. Menstrual bleeding scores and sort of descriptions of cycle regularity were similar at both 2 and 4 years, and there no difference between the groups, and neither was there any significant difference between participant reported overall satisfaction with the procedures that they had had. Next slide, thanks. Now, think about fertility. Now, this has been of great interest, and it is quite difficult to quantify. So the FEM trial did not exclude women who were wanted to get pregnant, but we couldn't really track pregnancy intentions over time. I mean, if you remember the previous slide, 48% said that they had pregnancy intentions at the time of randomization, but that doesn't mean that they were actively trying to conceive, and of course things change over time. In that era when the trial was recruiting, there had been some concerns about the impact of UAE on fertility and live birth rates, but that was based on very limited and potential biased data. Now, the figures here are what we call the intention to treat population. So they're in the groups to which they're really, originally assigned, irrespective of whether they had the procedure or not. And it does appear that there are more pregnancies, but more miscarriages in the UAE group. But first of all, just to point out that these numbers are small and could appear completely by chance. And if you actually look at this breakdown by the treatment that they actually received, of those that responded at 4 years, and we'd got losses to follow up there. There were 7 live births from 6 women who had a myomectomy and 5 births from 4 women in the UAE group. So there was no difference in the rate of getting pregnant and having a baby. Next slide, thanks. So whilst we saw significant improvements in both groups, it is inevitable that some women will want or will require a second procedure to control their symptoms. We captured this by self-report, perhaps continuing a little past 4 years for the earlier participants. The cumulative repeat procedure rate was 24% in the UAE group and 13% in the myomectomy group. So reflecting that a little bit less effective, as we saw in the 2-year follow-up. So next slide. Justin's mentioned that quite often we look at costs and also this standardised quality adjusted life year in order to evaluate cost effectiveness. So whilst myomectomy is associated with higher initial costs because it's a procedure that's performed under general anaesthetic and has a median length of stay in hospital of 4 days, which that compares with 2 days for UAE, which is performed under local anaesthetic. This is offset by more short-term readmissions and more repeat procedures, as we just saw in the UAE group, meaning the overall costs are very similar and the QALY difference was marginal. That said, if we look at the threshold used by NICE to recommend things, we see that myomectomy had a greater probability of being cost-effective, being 96 probable at 4 years. So to summarise, both treatments, so myomectomy, the surgical removal, and UAE, which is this less invasive blocking of the blood vessels to the fibroid, they both improve quality of life substantially from the pre-procedure state, but myomectomy improves it to a greater extent initially, although over time that difference between myomectomy and UAE is no longer significant. The impact on menstrual bleeding and regularity is comparable, but there are more repeat procedures following initial UAE. This leads to only a marginal difference in the cost and effect. And whilst myomectomy has a greater chance of being cost effective, we feel that that measure perhaps doesn't capture the patient experience of that being a less invasive procedure. So it's important that GPs, gynecologists and other healthcare professionals should discuss both procedures as an alternative to a hysterectomy when they're both viable options and allow women a choice given all of the facts. However, in those that are perhaps seeking a pregnancy, the impact on live birth rates remains uncertain, and this is an area where further research is needed. Thank you.